I did not.
We had a new button.
Oh, you have a new button. Okay, because I was like, it's not ready for y'all just yet.
Sorry, guys.
No, it's gonna be in just a second. You have the link now, Tracy.
All right. Give me 1 minute.
Is Dr. Davis come across yet? Oh,
Yeah, I'm
there-
here.
Yeah, okay.
Is that your office you're in?
Yeah, I've kind of moved, so I'm in Fort Worth now.
Oh, okay, cool.
Yeah.
All right, I have it posted. Let me just go check to make sure it's accessible.
Let's see, what about Judson? There he is. Yes.
I had someone just come in on an iPhone who just joined the meeting.
All right, y'all are good to go.
Oh, I just need the iPhone to identify themselves and then we're good to start.
There's
Oh, it's Kylie.
Oh, cool. All right.
What about Judson?
Did
We
he
lost him. Is he still in the breakout room?
He is. I just moved him back. He should be here in just a moment. Dr. Borland, you are good to start.
Okay. I want to call meeting to order. This is the Polysomnography Advisory Committee. Please know any comments by the public are welcome and can be emailed to publiccomment@lsbme.la.gov. I guess administration, can y'all confirm the identity of all telephone and video conference participants? If the
Yes.
sound is clear and audible to the public and those on the video conference.
Yes.
Okay. I'm gonna call the roll and I'll say your name. Please say yes if you hear, and for the administrative members, if you could state your role. So Dr. Lauren Davis.
Here.
Joshua Johnson.
Here.
Chris Swallow.
Here.
Holly Foster.
Here.
Judson Willard.
And I can hear for capital.
And Dr. Swab. Dr. Swab.
He did say was going to step away for just a moment. So.
Okay. Could the other members please identify themselves? I guess Tracy's IT.
I am. 1 minute, please, Olivia. You may need to unmute Dr. Swab.
Okay.
Patricia Belton, I'm one of the attorneys for the board, and Lauren Suddeth is here too. She's also an attorney for the board.
Hello.
And then you have Olivia, who's our administrator of the conference today. And then Ms. Bartholomew.
Yeah.
And yes, Priscilla, licensing analyst.
Okay. So the last meeting, could we have them a motion to approve the minutes of the meeting?
Motion to approve.
I second.
All in favor, aye?
Aye.
Aye.
Okay. During that,
Aye.
the minutes carry. During our last meeting, we had questions concerning how we could accommodate new technology like the Inspire and how to deal with direct delivery home studies and some compliance issues with patients getting the results of their studies. As a result of those discussions, we set up another meeting with basically the physician providers and need to kind of review the results of that result. Basically, we felt that most of the issues could be handled by the present rules and regs with maybe some tweaking, and that if we were to have a need for sleep educators, that would probably require a separate classification or new credentials. I think we'd requested or suggested that framework for a document come from that. Was that Dr. Davis or the attorneys worked on that?
Yeah, so we did do a I'm sorry. For a statement of position, we previously had one that was a advisory opinion written to a provider regarding the home sleep test. So we did tweak that to meet the kind of what we were talking about with the supervision of allowing, nurses and other people in your office to be able to do that. I can share my screen and just see. I did want to get with y'all and talk kind of more about the language of that. And then also I included like a little paragraph at the end to incorporate like that we wanted to say, the first meeting that you go and you tell the patient how to set up the test, everything for their home sleep test has to be done in person, but the follow-ups there has to be follow-ups, but also those can be done via telemedicine. So I don't know if you want to get started on doing that or you want to, it's y'all's preference.
Yeah, I think we can start with that.
Sure. So I think that y'all can see it. This is basically, I just took the old one and kind of edited it for today's, best practices because that was about 5 or 6 years old. So just going through the background of why, we need clarification for the home sleep testing and the statement of position, that going through kind of just the basic definitions. And then similar to that other language in that second paragraph where we kind of redlined it during the meeting and just said, that the precise, it has to be, where is it? It says stated differently in the board's view, it's inconsistent with the law to require or expect patients to set up equipment, yada, 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 without properly educating the patients in person on how the prescribed medical testing necessary to diagnose sleep disorders is to be conducted. It's the board's opinion that such activity constitutes a practice and may only be undertaken or performed with respect to individuals located in the state by physicians, techs, technicians, respiratory therapists, and then we added in there appropriately trained healthcare providers when acting under direct supervision, which I think is what y'all wanted to include now. And so I have the definition of that right after that, saying direct supervision is defined as a supervision by a physician or a qualified healthcare provider currently licensed by the board, whose scope of practice includes polysomnography and who is present in the area when the procedure or service is being performed. That's just taken from the rules. And then at the end, while this initial visit may be conducted in person, the supervising physician may conduct the follow-up appointment to discuss results via telemedicine or may refer the patient to a specialist to discuss results. Because sometimes not everyone who just prescribes it does the actual test or the review. So feel free to tweak this however y'all want. If there's anything you think that we need to add, take out, or anything that, raises hairs that might cause a problem, please let me know.
Really perfect. No, that looks really perfect. After we had our meeting, I went back and I've been talking to different people, and they had brought up direct supervision of a physician, or could it be direct supervision under a licensed sleep tech? And your wording would cover either one.
That comes straight from the rules. I don't know. Can y'all see the screen when I change it?
Yeah.
Oh, let me see if I can.
Because I couldn't remember if we had specified it had to be a physician or it could be a licensed sleep tech. That a licensed sleep tech should be able to do it too, because they're going to be in the proximity doing direct supervision. So that makes sense to me, unless other people have problem with it.
I have a question, not necessarily a problem, but I remember just saying if they didn't explain how to do this, like if they just walked up, handed it to them, or picked it up, they didn't have to be registered or a licensed sleep tech. So where does that go with dentist office? Because we're kind of seeing some stuff that I don't know or see where there's necessarily connected with sleep, like a sleep tech doing it.
I don't think the dentist can actually get
Dentists.
paid for it.
Yeah.
So I think they just do it and they don't get paid for it.
Okay.
And I don't know how, do we have regulation over doing testing? People can do all kinds of things to check, follow snoring. They have pulse ox on their watch. I don't know. It's getting kind of blurry.
Yeah, that's the problem. I think you can order this stuff online.
Yeah.
And they supposedly have the physician there, a physician reviews your questionnaire that you answer, and then he says, oh yeah, you need this, and then you get to buy it online. There's nobody in the state that has anything to do with the transaction at all.
Why would a dentist be involved?
Dentists do oral devices.
Oh, right. Sorry, I'm new to this, so I'm learning on the job here.
Oral appliances, but yeah, that's we saw something like we got a referral from somebody, or actually we had somebody come in for a study and they had it basically at a dentist office, their initial. And so it was kind of like, oh, okay, well then who set you up? Yeah, who actually did the study on you?
Well, they can't order CPAP. They can't do treatment. All they're doing is a test that they don't bill to monitor the efficacy of their dental device. So I don't know. Is that under our regulation?
No, that wouldn't be. Well, again, it would have to be if that were the practice of polysomnography.
Right. So that's why that the first paragraph of this does set out, what that means. It's the performance of sleep diagnosis under the direction and supervision of a physician, and then it defines the technology. So maybe that could kind of narrow that. And then this is where I got the direct supervision. It's part of the rules that I highlighted here. That's really just copy and paste. I want to make sure the language was consistent.
Am I muted, or can y'all hear me?
We can hear you.
Okay, one question I had with the wording of it, one of the things we discussed was that there are cardiology offices that have physicians in the building, and they are distributing home sleep test equipment using LPNs, and we were trying to cover that in this. And I know we said under the direct supervision of a physician, but it sounded like it said a physician trained in polysomnography. So is this going to allow cardiology offices to distribute the equipment, which I think was one of our intended things to accomplish?
Well, that would be if we decided that a cardiologist was a qualified healthcare provider currently licensed by the board. It doesn't say currently whose scope of, well, no, it does. Whose scope of practice includes polysomnography. Yeah. So we'd have to.
Where? Where are you looking?
After footnote 7, direct supervision is defined as
Oh.
supervision by a physician or qualified healthcare
Or,
provider.
yeah, so,
Yeah.
but they'd be a physician under that,
But
right?
their
Oh,
scope of
whose scope of
practice.
practice, right?
Yeah.
Mm. That would be a rule change. That's
Yeah.
not a linguistic change.
Well, I think part of what brought all this up is there are a lot of patients. The technology is changing things. We talked about dentists, and we talked about people are getting it online, and then part of what's happening is a lot of cardiologists are trying to screen for sleep apnea, and they're doing this now. A lot of them, thousands of studies every year around the state of Louisiana are being done through cardiology offices, and then they have very little follow-up. So
Yeah.
some of these cardiology offices are asking me to read the studies, see the patients, et cetera, for Greater Baton Rouge, and I've said no so far because the rules don't allow what they're doing. But all they're doing is handing out watch pad equipment, which is a watch with basically something that looks like an oximeter, and they're using an LPN to do it. So I don't think I don't think the intent is to prevent screening, but we do want some supervision. And I'm just trying to make sure if the rule says you have to be a board certified sleep doctor to distribute the equipment, that's only happening in probably 20% of the studies at this point. And I think we need to either change the verbiage, or if we think that this shouldn't be happening, we're going to have to do something about it. But to me, it's reasonable for them to be able to do the test as long as it's read by a sleep physician.
Right.
I think we were trying to if you had direct supervision, you could have a medical assistant hand out the equipment or instruct the patient when the equipment is handed out.
I wish this
So-
comma wasn't here because it reads like a physician or a qualified healthcare provider currently licensed whose scope includes this. That seems like maybe if only this little clause was only related to the qualified healthcare providers.
Well, I think the first part of that paragraph, Dr. Bordelon, takes care of it being that an allied that a mid-level or a qualified mid-level, you could delegate, the physician can delegate that to that qualified person. The problem comes with the supervision because it says under physician direction and supervision. And then we dial back to what the definition of direct supervision is. Now, it doesn't say requires that devices under supervision. Does it say direct supervision? Because direct supervision is different than supervision.
I think we want direct supervision. Yeah, the other thing to keep in mind is now the AASM is actually accrediting cardiology offices and other associated offices to be, accredited. I forget what the terminology is, but they would qualify if they did that.
So
Then
some of them might qualify under this.
I don't know that any, I don't know of any in the state. You know, the cardiologist, this whole WatchPad thing is because WatchPad provides life vests for the cardiologists. And so when they bought the sleep testing equipment company, they already had the ins with these cardiology offices, but none of these cardiologists that I'm working with anyhow have any special interest or any interest in sleep. Really, they are just ordering them because they've worked with this company with their life vest forever, and the same, rep is coming in and saying, oh, well, now you can do this too. And so I don't know that any of the cardiology offices that we in our area have this AASM accreditation for, and I forget the terminology, but it's basically set up for cardiologists and other associated physicians that also treat sleep patients so that they can do home testing through their offices. So there is an AASM accreditation for those cardiology offices if they wanted to pursue it, and then they would fit under this scope of practice includes polysomnography.
Right. What if one, so the link between the qualified within the scope of practice is meant to mean that the direct supervision has some teeth to it. Like the direct supervision is coming from somebody who knows what they're doing, even though it might be being done by a mid-level of some sort or delegated to somebody. So
I mean, we could put a position statement that defines what we're saying about, physician whose scope of practice includes polysomnography. We could put in a thing that defines that means that they're AASM accredited as a, and if I take a minute, I can go and look up what that term is, but a cardiologist can make part of their practice.
Just put the link in the chat.
Yeah, I just put the link in the chat for you because it does say if they go through that accreditation, they have to be working with a sleep lab who can perform full in-lab sleep studies. So that way the patient gets, the care they need.
Yeah. So, but that what we're going to have to do is the WatchPat people would have to be aware that if they're going to continue the practices the way they're doing them now, one of the cardiologists in these practices has got to be ASM accredited as a sleep, a home testing provider. I don't know.
And that's what you want it to be. You don't want it to be a situation wherein a cardiologist says, hey, I think it's a good idea if you do this, but just make sure a licensed sleep technologist or a licensed physician in polysomnography reviews the results or reports to me on the results or something. I mean,
so as long as we require that the interpretation and follow-up be done by somebody, and
I'm just asking, is that a different bookend that you would be willing to live with if you think these cardiologists, that there's some value in them starting the process, but that it's the finishing of the process or the interpretation that's the real issue?
I think they would prefer if a sleep doctor picked up the patient after the diagnosis. I don't know that they have a particular interest in treating sleep apnea.
Right.
So, I can't imagine that we can start talking to people out in the community and see if anybody has a problem with, you can supervise somebody in your practice that you train on WatchPat, but then it's got to be interpreted and have a path for follow-up with somebody that's trained in sleep.
Yeah, I mean, I think that might be your best bet, or a good alternative to saying we're only going to let people do this if they've gone through this accreditation.
Yeah.
I think what you said makes sense, and that is we want the sleep study interpreted by a sleep physician and follow up for the patient to be offered with a sleep physician. Who hands the patient the WatchPat is not as big an issue as they don't get any follow-up. And right now, a sleep physician with the state of Louisiana rules as they are is not supposed to read that test because the test was not done according to the current rules. But the rules are making it where now the patient's getting the test. I can't read it, and therefore they're not getting any follow-up. So I think we want it to, and tell me if I'm wrong, that we want it to be more about the patients, the studies being read by a trained physician, and the patient needs to be offered follow-up with a sleep provider.
Yeah, I agree.
I think you could really run into the issues of them sitting on a WatchPat, and then let's say their AHI's 15, 12, something, and they go, all right, WatchPat, APAT, bye. And really not getting
right,
actually treated.
Agree.
Yeah, so there would be some kind of language that would say sleep devices, equipment, and patient instruction. Initial device, that initial can be performed by a physician or a licensed physician who does not have a specialty in polysomnography, provided that the results are, the difference between giving them the equipment and doing what needs to be done once the results come in.
Right.
Yeah, we could say it's provided to them through a physician office, someone that's board certified as a physician in Louisiana, and the test is interpreted by a board certified sleep physician and follow-up offered with a sleep physician, something like that.
And that allows the commerce part of the actual equipment to be done by people who may only be in it for the money of distributing those devices, but it gives the backstop of you all being the ones who actually do the medicine
it.
related to it.
Yeah, and I do think there is some value to them distributing equipment because the patients in their office, you have a higher hit rate on your screening. They're in their office, they've got atrial fibrillation or congestive heart failure or, you know, a bunch of PVCs, and they need a sleep study because they snore and they've got a 20-inch neck. But they also need follow-up. So they need the
Right.
study, which is not complicated, but the follow-up is the part that's missing.
Right.
Okay,
That
cool.
makes sense
So
to
we
me.
can work, yeah, I just wrote some notes. We can work on language on that and we'll just add it to the end of this. Is there anything else that we need to address in this? Like, keep in mind, like, this statement of position is our statement, right? So it can have as much or as little as y'all want in it. So if y'all want to add other things to this within this, the parameters or, I mean, somewhat related to home sleep testing, like, now's the time to do it. So
Yeah, I mean, the only thing we butt up against is that there are laws and rules in place. So I think
Right.
to suppose we can say what we think best practices are, but at that point it's just aspirational. So if we want this to be a rule, it will have to become a rule. But certainly the statement of position can articulate that as a best practice while we work on a rule change.
So we're going to do two things. We're going to add that the interpretation and follow-up for testing must be done by somebody boarded in sleep, but then we have to circle back and look at that wording, that scope of practice includes polysomnography too. We would have to take, I guess, by a physician. Yeah, the comma needs to be someplace else because either by a physician or somebody that's scope of practice includes polysomnography.
well, it seems like, I mean, I don't know how these rules were drafted. I mean, like I said, that's just copy and paste. I didn't add the comma, but that phrase does seem to qualify the licensed healthcare provider because it seems like a physician can do it, but then also a healthcare provider licensed by the board, that's only specifically someone who is scope of practice includes that.
So I guess we need
Yeah,
the
although
grammar
I-
police to figure out the comma thing.
Yeah, but although I do think that alternatively, it could well have been when that rule was written that it was not as common, that there
Sure.
was an attempt to keep this within a circle of licensed either physicians or qualified, healthcare. I see the advantage of it now since this has become more widely used maybe than it had been when these rules were written. But I think in the beginning, the direct supervision was intended to be by somebody in the field.
Yeah, I think if we
Agreed.
just change the commas, it changes the meaning of it, though.
Yes.
It would separate the physician from the qualified health provider whose scope of practice includes
It
polysomnography.
does. It does.
Right. But
So
I mean,
just
I
taking
don't,
out the comma changes the whole thing.
but I don't want to take out, I wouldn't want to take out the comma and change the whole thing when the rules specifically are like that.
Right. Right. That's
So-
the problem. That's
so
how the rule is
We
written.
can change it for this, the statement, but it's kind of misleading.
I had one more question.
Yeah.
When it comes to direct supervision, what exactly, what I mean by that is if someone was operating in, I don't know, Leesville, and the doctor that's the direct supervisor is in Grand Isle, is that really, direct supervision, or is that, I understand our limitations because the board sleep, certified doctors and all that kind of stuff. So I'm just asking exactly, because I'm sure someone's going to ask me, well, what is direct supervision? Do they have
Yeah.
That
They
would
have
not
to
be
be on site.
considered. Yeah.
It says in the area, whatever that's supposed to mean.
Where you can walk over if somebody needed
Yeah,
help.
you're
and
not,
help
you don't have to be in the room, but you have to be in the next room or in the facility.
On the premises.
Yeah, I'm good with that. I was just like that. Because you're seeing more and more where, we're remote scoring or remote reading or remote. And so yeah, that's our doctor, but he might not be anywhere close to being in, where he can walk in the room.
Yeah.
Right. I think direct supervision is separate. It's defined differently than direction and supervision, which is in the definition of polysomnography. When the direction supervision down on this footnote, that says that you don't have to be physically present at all times. You just have to be like accessible in person or by the phone or other electronic means. So I don't know why those are so
I have
different,
a
but
comment
they
about
are.
the getting the results. A lot of patients are not able to connect because of poor internet. So could that statement say to discuss results in person or via telemedicine if the patient has access?
Yeah. I was going to work this whole little last bit to include but we can just workshop that now if we want to.
Internet access, I guess you should say.
Okay, so do you want to maintain a requirement that the initial visit in which the test is given to the patient and instructions are given to the patient on how to use it to be done under the direct, either by the physician or under direct supervision of a physician or qualified healthcare provider? And when we say direct supervision, we mean in the area. Or do you want it to be at the direction of? Which
There's still some companies that are mailing equipment out, and so I think by having this in person, you limit that.
Well, you do and you don't because because you do and you don't, because the commercial bit of somebody walking up, going on the internet and ordering the device is different from that vendor practicing polysomnography.
Yeah.
I think this has come up before that there's no way to enforce anything with that. And so I guess the enforcement, from what I understood, was that, they need a board certified physician to do the interpretation. And so the enforcement would be on the physician end, that we shouldn't be doing interpretations for drop ship home testing. Is that correct?
Right. That's the direction you all had been going in.
Because there's no way for the board to enforce with some company out of state that's doing that. But we can say that you have to be a licensed, to do an interpretation, you have to be licensed in Louisiana. And if you're licensed in Louisiana, you need to follow the board recommendations, which would be that, whatever we decide those are.
Right.
So we can't go after the companies that are doing it, but we can go after the Louisiana physicians that are doing interpretations for dropship studies.
So interpretation results from the sleep study must be conducted by a licensed physician who is board certified
in sleep medicine and licensed in the state of Louisiana.
And so do you want to say after that, have a sentence that they can be connected for follow-up? How do you want to address the follow-up section? And offered follow-up.
And treatment plan.
Interpretation and treatment plan.
Yeah.
Interpretation of results and determination of treatment plan.
Oh.
Okay, but you're still wanting to close the loop on, we say the initial visit must be conducted in person. So after that, the supervision may conduct the follow-up appointment via telemedicine. Okay, yeah, it's right there.
So do we have to have a rule change to do what we're trying to accomplish?
If we want to enforce it, probably. And
And
we could
how
also
would
get
we
rid of
get
those
the-
darn commas.
How would we get that rule change to occur?
It's
We
a long,
draft it, you vote on to recommend it to the board approves it, and then we begin the process. We have to do a notice of intent, we have to prepare a fiscal impact study, we have to have public hearings and receive public comment. We have to have a legislative oversight committee review. They may or may not hold a hearing. Then we send it to the Attorney General's office. They review it for anti-competitive aspects. And if they pass it muster on it, then it comes back to us and we can send it to the legislature one more time. And then it goes to the governor, who can decide if he wants to approve it or not approve, if he wants to disapprove it. He doesn't have to do anything to approve it. But if the time lapses without him not approving it, then we publish it in the state register, and it now is a promulgated rule that has the force and effect of law.
that would be a 2025 result, probably. It's a fairly lengthy process.
Has there been any problems with any other rules that you've tried to pass where you've limited that things have to be done by people that are licensed in the state?
As long as licensed by the state. It doesn't have to, yeah, licensed by the state. I mean, we have compact licenses now. We have telemedicine permits, registrations. And so it doesn't have to be someone necessarily physically in the state. Although this rule says the first visit has to be in person, but let's assume it's the cardiologist does the first visit and then everything after that takes place by a person licensed by the state. Whether or not they're in the state or not is not the real question.
Yeah, I'd change that.
Trying to figure out where's the blowback going to be.
So as long as you can demonstrate medical necessity. I mean, that's just like saying we don't let dentists do heart surgery. Why is that? That's anti-competitive. Well, it's because they're not trained and they can't, and it's a danger to the public and all of that. So I don't think we're not going to get anything substantial opposition to that unless you're aware of a group of practitioners who think they are trained to do this and they don't need to have a license and they don't need to.
I mean, I can't imagine who's going to have a problem with this. So I guess we can start this process. I mean, even though it takes a couple of years, I think if people have a heads up, they make the adjustments to follow the eventual rule, don't you think?
Yeah, oh, absolutely. And it's not, it's more like a year. It's not 2 years, but it's more like, it would be sometime in the latter part of this year that it would finally get done. But that's not necessarily up to us. Those deadlines are set in statute. And so we, a certain amount of time has to lapse between the beginning of each period and the end of each period. And that's, sometimes in the area of 6 to 7 months. So, but yeah, I mean, I think this is a very legitimate rule. And if somebody makes the beauty of the process is that anybody who really cares can submit a public comment or can come to the hearing and explain why it's not a good rule. And it may be something that we haven't thought of. And in that case, we can change the rule at that point before it's finally promulgated. But it's a specialty area with licensing and certification and training. And if you're going to have it, you might as well have it right. I mean, I don't see a problem with that at all.
So let me kind of review to make sure I have this right in my head. I'm sorry if I'm keep going over this again. So what we're saying basically is that when a home sleep test is ordered, it has to be set up with the patient in front of them, and it has to be done by either a physician, a licensed tech, or somebody that's been trained to do it, and there's direct supervision by either a physician or a licensed tech.
Right. I just
And
highlighted
then-
that section.
Okay. And then the initial follow-up after the test, when they have it, must be conducted in person to initiate care, go over the results of the test, come up then, but then it can go to telemedicine after that.
That's not how it currently reads. What we're calling the initial visit is the distribution and setup. If you want the first follow-up to be in person, we would
No,
have
I
to-
don't necessarily. That's why I'm
Okay.
trying to make sure I have
Yeah.
it right in my head.
No, the
Because I remember
initial
y'all saying
visit,
before that, people might live, 3 hours away. They're not going to want to come back for a follow-up and then just not do it. So,
So I think we need to change that line. The initial visit for distribution of the home testing equipment, rather than the first visit, because the visit is kind of nebulous. What do you mean by visit?
Yeah, okay.
So first of all, the equipment can be distributed under the direct supervision of a physician. Does not have to be board certified in sleep. They've got to be board certified in some specialty and licensed in Louisiana. Once that equipment is distributed, the test needs to be read by a board certified sleep physician, and follow-up needs to be offered with a board certified physician in sleep, whether that's telemedicine or in person. Correct?
Yeah, right now how it reads, interpretation of results from the sleep study and determination of treatment plan must be conducted by a physician who is board certified in sleep medicine and licensed by the state of Louisiana.
so in order
I
to
think-
accomplish that, which we can say in this statement of position is best practice, we have to change the rule that says under direct supervision, because direct supervision has that quirky definition.
And the new rule would read under direct supervision of a physician rather than a sleep. What would it read?
We needed to change the comma so that it's not the physician who has to have the scope of practice, including polysomnography. It's just the qualified health provider. So that means you could have a licensed tech that's in the room or in the building, or any physician in the building.
Okay, and we're just
Like-
gonna assume that physicians are gonna be responsible enough to know that they're not handing them out like gumballs and candy. They're handing them out with an understanding of what they want the patient to do and why they want them to do it.
You can't babysit everybody.
Well, that's what I'm saying. We're relying on physicians like we do rely on lawyers not to go outside what their knowledge and expertise is. That's a violation of the bar discipline, and it would be the same thing for a physician who
Right.
practices, who purports to practice outside
Something
of.
random.
Yeah.
Yeah.
If you get one outlier like that, then I think you punish that outlier. But yeah, right now I think we need to start the process of the rule change because the technology is changing faster than we are. And, we don't want these things mailed all over the world and get no follow-up. But we also don't want to say it's only sleep physicians' offices that can distribute home sleep equipment in person because there's such a huge gap between those two things. We want the patient follow-up to be right. We want the test to be interpreted by a sleep physician. And if the test is not being done right, that sleep physician is responsible for speaking up. But right now, we have two groups. One that's kind of rogue. They're operating independent of any sleep physician and no punishments being given. And then we have the ones like us that are doing it by the book. And there needs to be some middle ground due to the technology.
I think this kind of does it because they can dispense it, but they just have to have either a licensed tech or some type of physician that's in the building if the patient doesn't understand the testing or looks like they can't do the test, or they believe there's a contraindication. Somebody could say, evaluate the situation.
Agree.
And then they have to having the interpretation done by a sleep doctor. Like you said, a responsible sleep doctor, if he's seeing bad quality studies and a high percentage of studies that are inadequate, hopefully would step in to fix the process.
Yes, agree.
Okay, so given that we want to do the rule change, and so this is my suggestion. Y'all can vote today as a quorum of the advisory committee to ask Lauren and myself to promulgate a draft rule to present to the board that would accomplish what we've just said. It's going to look like this. I don't see a whole lot of value in doing a statement of position that's contrary to the current rules if we're going to change the rules.
Agreed.
And once we do that notice of intent, it's out there for all the world to see that that's what we're going to do. So
Okay.
if you want to vote today to tell us to go to the board at the January meeting, that on your recommendation to accomplish a rule change along the lines that we've just spoken of, then we can get that started. I don't know if we probably won't be able to make the February 10th. I don't know. It would either be February or March before it would go to the register for the first time as a notice of intent.
Yeah, I think that's good advice.
Do I have a motion?
Oh, wait, I'm sorry. So we're going to do both things. We're going to add that last paragraph, and then are we going to address the comma too?
So instead of doing this statement of position, we're gonna basically
the whole
scrap
thing.
this, do
Okay,
the rule
okay.
change, because
Okay.
the notice will kind of function in the same way of a statement of position, because they'll know that we intend to change it.
Okay.
But it's a good framework, at least to have something written that they know.
Okay. I'm sorry, Dr. Milan, I didn't mean to interrupt.
Okay. I just need a motion to proceed with
Motion to
drafting.
proceed.
Yeah, motion to proceed with a rule change as advised a minute ago.
Second.
All in favor?
Aye.
Aye.
Any opposed? So the motion carries. Will this document show in the minutes, the online minutes?
This one currently, probably I wouldn't think so, because it's a draft.
No,
But,
but
I
the
mean-
minutes can reflect the
Discussion.
components of the elements of the rule change that you want.
Okay. Any other discussions on the home sleep testing? So the other item discussed with the physician meeting was the nerve stimulation therapy, Inspire, and new technologies. Do we have any any more documents out on that?
It looked like there was something from Tosh that he and his the ENT surgeon that he was working with had some concerns. I think that it was more of they wanted to make sure that techs were getting some training. And I think that the Inspire, it sounded to me like it was being driven by the Inspire people want to make sure that they can certify techs that haven't had training before. And I think we kind of talked about that. Yeah, I don't know if it's, when you only have one company that's doing that type of procedure, it makes it kind of difficult because I think that it makes us feel like we want to say, all right, well, let Inspire certify everybody. But, there are going to be other hypoglossal nerve stimulators coming in. And so we can't specify Inspire like we talked about last time. It just has to be, we just have to put in something nebulous that, we need to ensure adequate training. But I don't know what you do with that.
Hey, Tracy, while they're talking about that, would you double check and make sure there weren't any public comments related to the previous motion?
I do not see any public comments.
Okay, thank you.
You're welcome.
Well, that's
It-
good.
As I recall, we thought that we could tweak the present rules without having to change to accommodate each new technology that comes along. So,
So we just leave it as is, I think.
and that as that students that are coming out right now may be trained a little bit differently than students that are coming out in a year where the information might be included in their curriculum.
But basically, it's the responsibility of professionals when they're out in the field to update themselves on new things.
Yeah. The individuals as well as the institutions that might be doing the testing or the devices.
So we're kind of feeling like the hypoglossal nerve stimulator is not so novel that it doesn't apply to any of the other technologies like IVAPs and all the other things that come out that we train and come up to speed on. I mean, you know, if every new technology we had to have a position statement, it would be kind of crazy. So we're just going to kind of say that, you know, if you're the medical director of a sleep center or you're a hospital that has a sleep disorder center, that, you know, you should be ensuring that your personnel are trained in what you're doing in the lab or the center.
Yeah.
Yeah, I think that's how we left it last time, that basically the tech is changing so quickly that we couldn't and shouldn't, try to legislate for each individual thing. Because by the time we get it through, there'll be something new on the horizon.
Any additional comments? Concerns, comments online?
There are no public comments.
Okay. So we'll work on the draft, and the draft will be presented to this committee or goes to the board.
The draft of the rule,
Yeah,
it's up to you. If you want to make it on the January agenda, we would have to do it and then let y'all see the result. Keep in mind that what we present to the board would be conceptual and subject to change with the hearings and the public comments received and so forth and so on. It wouldn't necessarily be the absolute final version. If you want to approve word for word the final version, then we would bring that back to you at your next meeting and put it before the board at the February meeting.
Anybody comment? How would y'all like to proceed?
If you want to pick one person who has a particular special interest in this and wants to, we can run it by that one person once we get it drafted. We just can't have an official action of the board without a meeting. If you want to designate Dr. Bordelon, Dr. Davis.
And that's basically to just approve a statement about staying up to date.
Oh, I'm sorry. I thought we were talking about the rule change. I wasn't in on the statement up to date conversation. So y'all are talking about putting out a position statement, or you're talking about?
No, I think we were trying not to.
Yeah. I don't know. This is something that somebody reached out to y'all about. They had a question about it or something.
Well, I think it had come up that we don't have, do we need some kind of I don't know, to address the fact that this new technology is out there and that it's a new procedure that's being done in sleep labs. And do we need to, specify what the training should be? And I think we decided, no, we didn't want to do anything like that, that we were just going to lump it under things you learn after you've been in training.
Yeah. I would just leave it alone. I think that just, it's kind of like an unwritten, like somebody just said it, we assume that people who are doing something have taken the time and effort to appropriately be trained on it. If we ever started getting complaints about it or something like that, we might have to address it more specifically. But yeah, I don't think you need to.
And I'm sorry, you were needing somebody to read the draft for the change in home sleep testing?
I thought that's what Dr. Bordelon was
Yeah.
was referring to. If you, we're happy to send it to you. If you just want one person to say grace over it before it goes to the board, that's no problem. I just can't have all of you do it unless we have a meeting.
I mean, I'm very active with the hypoglossal nerve stimulator right now. I have 4 surgeons in my community doing it, and I'm seeing quite a few patients. I'd be more than happy to do that if people trust me to do that.
I trust you.
That's
I
good.
trust you.
Yeah, so if you want to send it to me, if I see anything that looks weird, I can, let you know.
Okay, that's when we were going to do a statement. Are we still doing a statement?
Okay. Yeah, the statement.
No, I think I'm getting confused now. I think you were talking about sending
Talking about
the
the home
revision of
study.
the home testing, right?
Yes.
Yes,
The home
that's
testing, yeah,
direct
but-
supervision. Yeah.
Get the stimulator.
And I thought that we had, you all had pretty well instructed us on the exact wording that you wanted, but if you want somebody to look at it one more time before we put it on the January agenda, I'm happy to send it to one person, just if y'all designate somebody to look at it.
I'd kind of like to look at it.
Okay.
I have comma concerns.
Okay. Okay. All right. So if it's the will of the committee that we'll pass it by Dr. Davis at the same time we put it on the agenda for the January board meeting. That way we can get it rolling with their approval and hopefully get it to the Office of State Register in February or March.
I like that.
Hearing no grave objections, that's the way we'll go.
Okay.
Okay.
Do we have any other business that anybody wants to bring up?
I think the last thing was the sleep educator licensure.
Yeah,
Right.
yeah. I did have someone reach out to me, not about that, about another question. As far as the STAR programs and with the state, I don't want to lie, let me read it. Is it a current pathway to an LSBME RPSG license if the BRPD exam has been passed with the STAR program? And their second was, can an accredited program like Southern University of Shreveport offer a STAR program?
I think they can offer A-STEP, the 80 hours of instruction of A-STEP if they've developed it, right?
Yeah, they have an A-STEP program. Southern has an A-STEP program. Last May was their first class to come through. He was asking about the STAR, which we originally, like our first time I was in a meeting, we talked about that and got it all, and they were asking whatever happened with that, like it was put on the law or in the books or something. I thought we never really got an answer as to if that was approved or done or all that. That's what the question was.
Is that the program that was through the AASM?
It was through BRPT. And so our conclusion then was, if you take the BRPT registry and you pass it, then, you should be able to, if the BRPT sees that as the pathway and you pass and you're an RPSGT, then you should we should give them a license, because a lot of us, myself included, never went through any of that.
I think the BRPT, if you're already passed the test with BRPT, you can get a license, right?
Right. They were asking which to me that was answered. There isn't the first question with the can you take a STAR program and pass the BRPT and get a license? But what they were asking was, when we said that, it seemed like that was never actually finished. Like, we put it all in there. That's what we dealt with. It was like 8 years ago when we started doing all this.
You can do a step as a pathway, and I'm trying to remember if there was alternatives that if words of organizations changed but there was an alternative pathway, and if you went through like the A step and then passed the boards, you could get licensed. I'm not sure that anybody has achieved that.
I would have to go look back. It's been a long time, but if from what I recall, but I would have to double check it. If you pass the BRPT exam, you could get accepted to get a license. And so whatever the BRPT uses for their prerequisites to sit for the exam, if you pass it, I think you're eligible for a license.
Okay, that's what I told them. They just were asking for clarity because I
Yeah, I
remember
can
the
go back
discussion
and
being.
check, but I don't think we teased out what, you had to do. I think the BRPT
Right.
is basically responsible for their, requirements to sit for the exam. But if
And that's
once
what
you
I told them.
pass it, I think you're eligible for licensure, but I'll double check that.
Yeah, because I remember the argument being with me and Wade was, we don't want to be hypocrites. I mean, we didn't go through that pathway. I'm not going to sit here and say that now everyone has to go through that pathway. If the BRPT says this is what you need to do, then that should be good enough.
When do we need to have another meeting?
Are we going to do something about the sleep educator thing, though? Is somebody going to, we probably need somebody that's a sleep educator in the state to spearhead that to see if we can get licensure for them. It's really, I think it needs to be a separate license, and so it needs to be independent from us.
Yeah, I think
Maybe,
that was the discussion we had. There would have to be a separate licensure.
maybe we invite one of them to the meeting at the next meeting to discuss it. Or is that something we can
Probably
handle?
if we could find, there's not many in the state. If we could find one in the state and then maybe have somebody from the BRPT to talk to us about it.
When's the next meeting? Because I take that exam this month.
That would
So
work.
if it's before, if I take that exam and pass it, I would be at the next February meeting.
Ah.
When's the exam?
I take it the last weekend in January.
And then I have somebody in my office that's taking it around that time as well. So we have a bunch of people in the pipeline. So that's why I think we need to address it sooner rather than later.
Yeah, I know somebody who currently has it. I can ask her to join the meeting in February with us. Just have somebody who's been utilizing it. I'm taking the exam, but I will not be utilizing it with my current position.
And it would be nice if we could get somebody from BRPT because they can tell us what's going on in other states with this.
Oh, I do have I have a contact who's on the BRPT that I could reach out to as well. I don't know if his schedule would allow it, depending like the day and time we pick, but if he's open, he could come, or he could, maybe give a contact from the BRPT.
Hi, my name is Phyllis Johnson, and I'm the supervisor of Allied Health. And we on this end we license the polys, and I hear the discussion of the BRPT, and yes, we do issue the license just based on that, with no particular educational requirement. That's not even required.
Great.
And also you were asking about, I heard this discussion about, I think it was Southern, but anyway, they're currently, I mean, I don't know if I guess you are aware, they're currently a K-HELP accredited program. So now there are two in the state.
Right. And there was actually their director, Colton, that was asking me if they could, since they're K-HEP, would it be possible for them to offer STAR, which is way faster? and I told him I would ask. I mean, I don't see, like I said, if it's BRPT approved and that's a pathway of BRPT, I don't see why they would not be able to, but I wanted to make sure.
I have a question. If they do STAR, would that be online or virtual too? Are there like hybrid type?
I can see. I've had one of their students come do her clinicals with me, and I have to tell you, they did a phenomenal job. Like I saw her AASM, ISR scores, and they were 98, 99, and that's ridiculous for pretty much anybody, but especially a student that's never done sleeps before. So, and she knew everything when I talked to her. She knew. So they're doing a quality job.
Oh, I want to steal her from you.
She's not with me. That's the thing. She's not even. She did her clinicals, and then I don't even think she's working. So it's yeah. But yes, they do a really, really good job.
So I guess for the next meeting, we'll go back and look at the original, what we talked about and make sure that the STAR is okay. But like she said, if that's what they're doing for licensure, they're just taking, no matter what your training was, if you pass the BRPT exam, I think that's really the answer.
Okay, do we want to schedule a meeting now for like maybe March, or do you want me just to reach out to Dr. Borlon and then we can get it scheduled?
Could we do March?
I was thinking March would probably be best.
Right? Y'all want to do 1 or 11? What works better for everybody?
It doesn't matter to me. Oh yeah, either way it's fine. 11 or 1.
Yeah, either.
Lauren?
Either one.
So Friday in March, 11 or 1 o'clock?
I have March 1st or March 15th. March 1st would give us more time if we need to have
Sorry. That's the odds of March. I'm sorry.
March 15th?
You 15th, 1st or the 15th, one of the two.
Do you think we'll need extra time to get things done?
I'm good with either one.
Me too.
Patricia, Lauren, does either of those work for you?
Either one's fine. It's just, I think what Olivia was referring to is if you took action that you wanted the board to subsequently act on, the earlier in the month you do it, the more likely it is it can get on the agenda. But I don't think that's anything we're talking about having something ready for March.
So March 15th then?
Okay.
11 or 1?
11.
Open?
11.
11.
11? Okay.
And the earlier works for me.
Yeah. If it lasts this long, 1 o'clock's too late.
So March 15th at 11?
Sounds good.
Okay. Motion to dismiss?
Yes.
Motion to dismiss.
Thank y'all all.
Thank you too.
All right.
Have a good weekend.
Thank you.
Uh-huh.
Thank you.
Bye.
Bye-bye.